Hey, this is Dr. Busti, and welcome to High Yield Meta Review's sponsored core drug interaction between cyclobenzaprine and tramadol. We'll both look at mechanism as well as the evidence. But let's first start off with a real clinical case scenario that may happen or you may have already experienced in your own practice. We have a 34-year-old male who basically has no past medical history who comes into clinic reporting that he had a mechanical fall approximately 1 day ago at the height of about 3 to 4 feet. He landed on the back left lateral side of his body, and he denies any fever. He denies any loss of bowel or bladder function, no lower extremity motor weakness, basically eliminating any concerns for more emergent spinal cord related injuries. He says his pain has improved with some use of naproxen, some Tylenol, but at night he's having trouble sleeping, especially with certain types of movement. And so he's only using naproxen and Tylenol as needed at this point. He has no drug interactions. Vital signs are stable, but rates his pain at about a 5 to 6 out of 10. On exam, you do note when you're looking at the back, he has a superficial abrasion from the mechanical fall with a little bit of ecchymosis. With certain movements, you see a muscle that does spasm intermittently. It seems to worsen his pain. His straight leg test is negative. And so the plan is, especially be given the fact that you are a little bit generous today and you feel a little bit of compassion against this guy, but giving some relief, especially at night when people sometimes have trouble sleeping, and knowing that he works construction. You not only continue the naproxen and acetaminophen, but that you're going to go ahead and give him a couple pills to get him through the next couple days of cyclobenzaprine and Tramadol. Tramadol is also marketed as Ultram, and cyclobenzaprine is known as Flexeril. But what happens is you get the all anticipated and most exciting thing that you usually experience throughout the day, which is an EMR pop-up alert saying, hey, there's a drug interaction. Do you really want to do this? Are you sure about this? And you know how most of us who get these pop-up alerts on our electronic medical records and systems, we sit there then and intently read every word of it so that we make sure that we fully understand that. Yeah, right. Most people just hit the X and move on. But it is relevant and it is important. But why does it pop up? So in order to answer that question, you need to have a basic understanding of some core pharmacology. Okay, and first we need to cover the main mechanism of action of tramadol or Ultram. So there's a couple mechanisms that are important to note. First is you need to recognize that tramadol is a racemic mixture. That means that there's two isomers, an R isomer and an S isomer. They're just mirror images of one another, but they're both pharmacologically active, and they do work on the mu-opioid receptor, and they work as an agonist, just like other opioid analgesic medications. The parent drug, okay, which means or implies that there is probably a metabolite, and there is, has very little opioid analgesic property, so it's pretty weak. It's about 1 to 6,000th of the potency binding affinity that you would compare to morphine. The active metabolite, which is generated through a metabolism via 2D6, has a significant greater binding affinity to the mu-opioid receptor. It's about 4 to 6 times more potent than its parent drug, and that's about 1 to 35th binding affinity compared to morphine. So, significantly more analgesic effect when it gets metabolized. In addition, it also is known to inhibit the reuptake of both norepinephrine and serotonin in the central nervous system. This has been estimated to be about 1/20th of the binding affinity to those receptors and transporters, basically, as compared to the tricyclic antidepressant imipramine, or also marketed as tofranil. Now, what about the mechanism of action of cyclobenzaprine or Flexeril? Well, there's really not much information about this drug that's been published. I had a hard time actually finding anything specific in the definitive data that supports this, but it is considered a centrally acting muscle relaxant. And what I mean by that is that it reduces the activity of the tonic somatic motor activity in the brain stem. that may have an effect on gamma and alpha motor neurons and helps relax the muscle. How it exactly does that is not known to my knowledge, but it has also been reported to have antidepressant properties that are similar to the tricyclic antidepressants. Now, to build on this drug interaction, let's talk a moment about how do tricyclic antidepressants actually work themselves. Well, there's two different types of tricyclics antidepressants. There are secondary amine TCAs, and then there are tertiary amine TCAs. The secondary amines are classically known as more nortriptyline, disipramine. They're used more in clinical practice, and they tend to work a little bit more on the norepinephrine neurotransmitter than the serotonin. So they inhibit the reuptake of both, but with these secondary amines, we get a little bit more of the norepinephrine effect. Whereas tertiary amines have a more of a serotonin effect in increasing those levels. So theoretically, it can increase the risk of serotonin syndrome a little bit more than the secondary amines. Again, amitriptyline or Elavil is pretty common. Clomipramine, probably one of the more highly likely to cause serotonin levels to be higher, and then imipramine. And so we use these in clinical practice, not anymore for antidepressant activities as much because of their toxicity profiles and need to monitor drug levels, but we use them in low doses to help people sleep. They have for neuropathic pain syndromes, and so as a result, they can work on patients who have underlying pain as well as a little bit of depression. Now, why are tricyclics called Tricyclics or TCAs? Well, it's because they have a tricyclic structure. And if you look at their structures, this is an example of amitriptyline and imipramine, which are some of your tertiary amines. You see that we have this tricyclic structure. And this becomes very important as we tie together the drug interaction with tramadol, specifically when you see amitriptyline. So if Flexeril is a muscle relaxant, how does it work like a tricyclic, and why is it a potential problem with the use of tramadol? So let's do a cross comparison. So we know that tramadol is a mu-opioid receptor agonist, but it has this reported inhibition of the reuptake of serotonin and norepinephrine. Okay. We know, and we just learned, that amitriptyline also inhibits the reuptake of serotonin and norepinephrine. They obviously, TCAs differ based on tertiary versus secondary amines, but they both do this, and you can see that structure that I just showed you a minute ago. Now let's look at cyclobenzaprine or Flexeril. You'll note very important similarities with amitriptyline. The only difference that is recognized with cyclobenzaprine is this double bond. And that becomes relevant. You know, we know in medicinal chemistry specifically that affects the binding affinities in interaction with binding pockets. And so there is this muscle relaxant activity, centrally acting, like I said before, and it possibly inhibits the reuptake of serotonin and norepinephrine. So then as we learn core knowledge, it is important to integrate it with the evidence. And so is there any evidence that cyclobenzaprine or Flexeril actually works as a tricyclic to inhibit the reuptake of norepinephrine and serotonin? Well, the only data that I can find is basically data that looks at two large pharmacologic databases and does computational predictions based off of structure binding affinities that are not basically looking at cross comparisons of the same in the same study. It's based off in vitro data from other studies, and so they do this computational prediction. And what they report is that Flexeril or cyclobenzaprine has on the order of two orders of magnitude less binding affinity or less potency as compared to the tricyclics amitriptyline and imipramine. And so yes, while it has some predictive likelihood of inhibiting the reuptake of serotonin and norepinephrine, it is significantly less than that of a tricyclic antidepressant. It is also important to recognize that this is not a study that did a cross comparison and did not use the same consistent in vitro analysis. So, we know that in vitro studies, there are differences in results that sometimes are used based on the assays and the method and the receptors that are used. and where those receptors come from. And so it's very important to put the evidence in its proper context. So now the important question is, well, is there any evidence that serotonin syndrome, because that's what we're worried about, now that you know that these drugs both increase norepinephrine and serotonin, this is what we're worried about. Is there any increase in the risk of serotonin with tramadol and cyclobenzaprine or Flexeril use? And the answer is no. I couldn't find any reports that actually cited a known drug interaction between cyclobenzaprine and tramadol. And I looked at a number of different sources, including PubMed. I looked in drug interaction facts, Goldfrank, Lexi Drugs, all these different programs to try to identify and look in textbooks of different sources that are considered reputable. And I couldn't find anybody or anything that reported this. I even Googled it, all right, because that's a reliable search engine, isn't it, right? When all else fails, Google it. But I couldn't find anything specific. I'm not saying that there isn't anything ever reported, but I couldn't find it, and it certainly wasn't cited in a lot of peer-reviewed textbooks that are very well known and used in medical education. So if there is something out there, it certainly isn't very well known, and it probably isn't of sufficient data to obviously prove causality. However, there are studies and case reports of tramadol causing serotonin syndrome alone. There are case reports of tramadol with tricyclic antidepressants causing, at least being linked to serotonergic problems. Tramadol with other serotonergic drugs. Cyclobenzaprine with other serotonergic drugs, but nothing specifically with tramadol and cyclobenzaprine. And so how could we have done anything different in our case, bringing it back to where we were and we started? Well, our original plan was to, let them continue naproxen and acetaminophen. We're going to be nice and offer them a little bit of pain relief, especially at night, by giving them a few pills of cyclobenzaprine and tramadol. But we got that dreaded EMR pop-up alert, right? We're now wondering, what do we do? So what are some alternative options? Well, one is don't do anything. I mean, this guy's 34 years old, has no past medical history. This is a fall, right? He'll get better. You can appropriately dose the naproxen and Tylenol. He was using it PRN, and you could put it at the correct dose and appropriate intervals and just make it regular instead of PRN use. You could just give him tramadol alone and continue to take the naproxen and Tylenol. You could switch the tramadol to Tylenol number 3 or Tylenol number 4, which basically Tylenol number 3 has 30 milligrams of codeine, which is Tylenol number 4 has about 60 milligrams of codeine in it. And so you don't have to worry about a drug interaction with cyclobenzaprine or Flexeril in that situation. Okay, you could change the cyclobenzaprine to any one of the other muscle relaxants, right? Baclofen, which works on GABA B, tizanidine, which is an alpha-2 receptor agonist that works in the central nervous system. Benzodiazepine, which I think is a little overkill, right? Works on GABA A. Methocarbamol, Robaxin, these are centrally acting agents. We don't really know. Metaxalone is the same thing. Carisoprodol, some of these centrally acting, unclear mechanisms, but they work to reduce spasticity and muscle relaxation. Those are all options that are theoretically possible. So let's pull all this together. So we've learned that tramadol is not only an opioid analgesic, especially when it gets actively metabolized to its metabolite that is more likely to bind to the opioid receptor, but it also inhibits the reuptake of serotonin and norepinephrine and theoretically can increase the risk of serotonin syndrome, but also at higher doses lowers the seizure threshold, right? We know that's an important problem with this drug. Cyclobenzaprine or Flexeril is not only a muscle relaxant, but appears to have theoretical risk of increasing the serotonin and norepinephrine due to structural similarities to specifically amitriptyline. Remember, only differed by that double bond. There's really no good evidence that I was able to find out there that would support that there's actually a drug interaction, but it appears to be theoretically possible and does warrant consideration, especially in an abnormal response that you would not otherwise predict. And while there is no evidence, that does not mean that the risk isn't evident. So I hope you found that to be useful, but also to answer the question of why you get that dreaded EMR pop-up alert and what to now do with it. We always need to learn things in our core knowledge, but we also need to put it in the proper context of the best available evidence. I hope that you found that to be concise, easy to understand, clinically relevant, and obviously oriented to the patient.